Welcome to all our netizens. Today is the final webinar in our OrthoRoCKs webinar series. We would like to thank all of you who have religiously joined us the past 4 weeks. Your support has been invaluable in making this project a success. I would just like to announce again that all the lectures will be available soon on the OrthoRoCKs YouTube channel for a limited time. On to our lectures for today. Our first speaker will be telling us all about Clubfoot, one of the most common congenital conditions we encounter as healthcare practitioners. Our speaker is a graduate of the UP College of Medicine in 1999. He finished his residency in orthopedics in 2004 at the Philippine General Hospital. He went on to do his fellowship training in pediatric orthopedics in the Royal Hospital for Sick Children in Glasgow, Scotland. He is currently faculty of the University of the Philippines, Manila Philippine General Hospital, and is an adjunct clinical associate professor of the Marquette University in Milwaukee, the United States of America. He is the director of the Gate Lab of the Department for Orthopedics, UPPGH, the only one of its kind in the Philippines. He is the president of the Pediatric Orthopedic Society of the Philippines. Let us all welcome Dr. Carlo Emmanuel Sumpaico.
Welcome, everyone. I am Dr. Carlo Emmanuel Sumpaico. I'm a pediatric orthopedic surgeon. Today, I will be talking about clubfoot. I have no disclosures for this lecture. So, what do they have in common? Believe it or not, all the people in this slide have clubfoot. This person, Damon Wayans, is an actor. Christy Yamaguchi is an Olympic gold medalist. Troy Aikman is a professional football player who played with the Dallas Cowboys. And for all the oldies out there, this is Dudley Moore, a famous actor and comedian. This is my generation. This is Steven Gerrard, a professional football player from Liverpool. He was captain of the football team and a Champions League winner. As in real life, there are heroes in our community, as there are villains, so much so as in Clubfoot as well. So this person here is Joseph Goebbels, the chief Nazi propagandist. All these people in this slide have clubfoot. The outline of my lecture are as follows. First, we will define clubfoot, differentiate the different types, describe the pathophysiology and pathologic anatomy, and finally talk about treatment. Specifically for treatment, we'd answer the following questions. What is serial casting and how is it done? How do we monitor improvement? And when do we know when to stop casting? Why do feet relapse and how do we handle them? And are there other methods in the treatment of clubfoot? So clubfoot is a more common of all the congenital anomalies found. It is usually found in 25.7 in 10,000 live births, and you usually see 100,000 worldwide. In the Philippine General Hospital, in our clubfoot clinic, we usually see around 100 new cases per year. Clubfoot is very easy to diagnose. Okay? It is one of those illnesses or things that once you see them, you already know what they have. So the components of clubfoot can be divided into four. It has four components. The first one, you have your cavus deformity. Second one, you can get your midfoot adductus, a varus heel, and your hindfoot equinus. It's very easy to remember. Just remember the mnemonic of cave. C stands for the cavus deformity, A stands for the midfoot adductus, V stands for the varus heel, and E stands for the equinus of the hindfoot. For the pathologic anatomy, or answering the question, what's wrong with my foot, we can divide the deformities via intraosseous or interosseous deformities. Intraosseous deformities pertain to the pathology coming from the bones, while interosseous deformities pertain to the soft tissues around the bones of the foot. So for the intraosseous deformity, so the one in blue is your talus. The one in red is your navicular. The one in yellow is your calcaneus, and the one in green is your cuboid. Normally, these are in line with each other. But with clubfoot, The navicular is medially displaced and plantarly deviated compared to your talus, while the cuboid is medially displaced compared to your calcaneus. This is a picture of one of the navicular that we dissected off from a patient with clubfoot. As you can see, the navicular is very deformed. So the deformed navicular is the one on your left. It is medially and plantarly deviated, and it is wedge-shaped. So the joint of interest in clubfoot is your talonavicular joint. So this is where the deformity happens. So for clubfoot, or the picture on your left, this one in blue is the area of your talus, and the one in yellow is navicular. So you can see it is medially and plantarly deviated. So the picture on your right is a corrected clubfoot, wherein you can see that the navicular is seated right on top of your talus. The interosseous deformities refer to the tight structures posteriorly and medially. And these are your tendons and your joint capsule. Clubfoot can be divided into 4 types: the positional, neurologic, syndromic, and idiopathic. Positional clubfoot are usually due to intrauterine positioning. Yes, they are part of what we call our packaging problems due to oligohydramnios, or the lack of amniotic fluid. So because the baby is squished inside the womb, a clubfoot deformity is formed. These things are usually benign and resolves on its own with stretching and manipulation. The neurologic and syndromic club feet are associated with problems in the brain and spinal cord, such as in cerebral palsy, spina bifida, and meningocele. Or they can be part of a syndrome like arthrogryposis and your amniotic band syndrome. So neurologic and syndromic clubfoot are the ones which are very difficult to treat, as they are resistant to treatment and they have a high rate of relapse. The idiopathic, or the most common type of clubfoot, previously had an unknown cause, but recently these researchers have found that they may have a genetic origin. So they have actually identified a single mutation in the PITX1 gene. The PITX1 gene is a transcription factor involved in early development. As said earlier, clubfoot is easy to diagnose. Once you see it, you know the diagnosis. But is it easy to treat? This was, in history, this was how clubfoot was treated. So you can see all these contraptions to try to forcefully correct the foot into submission. This picture here, this is actually called a clubfoot wrench. So this is a literal wrench to correct your clubfoot deformity. But we've gone a long way since these early times, and we can't talk about treatment without mentioning Dr. Ignacio Ponseti. His research on clubfoot started in the 1940s and published his first research on clubfoot and its treatment in 1963. However, it was largely ignored by the public and the scientists. It was only accepted in 1995 when he presented his 30-year long-term follow-up of his patients. So this is a picture or screen cap of one of his patients. So as you can see in the pictures on top, you have bilateral severe clubfoot deformities. And this is the patient after 30 years. If you did not see the pictures on top, you wouldn't know that this patient had club feet when he was a baby. You can see him walking normally with a good heel strike and toe off. He can hop on one leg and he can walk on his heels. So you can see that the patient has very supple feet. So what is the Ponseti method? It entails weekly manipulation and serial casting of the feet to gradually correct the deformity. These are a series of slides which show the progression of the correction. So you start off with this foot, and with serial casting and manipulation, you end up with a normal looking foot. So how do you do the Ponseti method or the Ponseti maneuver? Start off with a skeleton. First, you place your thumb to stabilize the head of the talus. Then, you supinate the first ray by lifting the head of the first metatarsal and then abducting the foot. this is how it looks like in a real foot. Stabilize the head of the talus via your thumb. Supinate the first ray by lifting the first head of the metatarsal and abduct the foot. Again, stabilize the talar head, supinate the first ray, abduct the foot. Okay. It's very important to know the sequence of events. First, stabilize the talus with your thumb on the talar head. Supinate the first ray by lifting the first metatarsal head. And finally, abduct the foot. Okay. So this is how we do it in a real patient. So you see here the proper way of holding the foot. You initially put the wadding sheet still with your fingers in the right position, stabilizing the talus here, supinating the first ray and abducting the foot. And then you apply your casts. Again, while applying the cast, you should still remember to put your fingers in the right position, stabilizing the talar head, supinating the first ray, and abducting the foot. You complete the cast, put them in long leg cast, 90 degrees with the knees in 90 degrees of flexion, up to 2 finger breadths from the crease of your groin. So this is a finished product of the casting. This is how it looks inside the body. So initially, this is how your bones look like. So again, the blue is your um, talus, the red is your navicular, the yellow is your calcaneus, and the green is your cuboid. So as you can see, as your correction progresses, you see that the navicular sits on top of the talus, and your cuboid sits on top of your calcaneus. So they are already they become in line with each other. So as anything in life, it is not easy to do the Ponseti method. It takes practice. So fortunately, there are aids to help us practice not on patients but on dummies. So this is a picture or a slide of how we do the Ponseti method, or a workshop doing the Ponseti casting. So for those who are interested in Ilizarov, so this is another armamentarium in your bag of tricks that the Ilizarov rings can actually be used as stands for our clubfoot models. So how do you know when to stop casting? So obviously there's an end to your casting. So when you can reach 70 degrees of hyperabduction of the foot, then it signals the end of your casting phase. Unfortunately, or most of the time, only the cavus, the adductus, and the varus heel are addressed by the Ponseti method. You are left with the equinus. Okay. So how do you address this left equinus deformity? So it has been recommended that you do your percutaneous Achilles stenotomy. It has been said that more than 50% in a study by Kempa, less than 50% needed a tenotomy. The study by Morquende in 2009, everybody beyond the walking age needed a tenotomy. And these tenotomies are majority done on as outpatient basis. So how do you do your percutaneous tenotomy? First, you prep the skin. Next, you infiltrate with local anesthesia. And then you cut the Achilles tendon 1 centimeter from the insertion in the calcaneus. If you look at the first picture and the last picture, you see a marked difference in terms of the equinus deformity. In the first picture, the foot is in equinus, while in the last picture, you can see a fairly good amount of dorsiflexion for the ankle. After this, you put them in a cast for 3 weeks. After 3 weeks, you put them in a foot abduction orthosis. A foot abduction orthosis, what we call a boots and a bar. They help maintain correction of the deformities. For babies who are still not walking or standing up, we usually put them 23 out of the 24 hours in a day. But when they start to stand up or are toddlers, we just apply them during sleeping time. And they are And they use these orthoses until they are 3 to 4 years old. So these are a few of the before and after pictures that we have seen in the PGH Clubfoot Clinic. So all the pictures on your left show patients with a club foot or club feet deformity when they were babies. They underwent serial casting via the Ponseti method, underwent bracing using the foot abduction orthosis, and here they are now years after. You can see flat feet, which are very supple. So, what are the results from Iowa? I mentioned Iowa because this is where Ponseti came from. So they are one of the um, places wherein there are long-term studies on clubfoot. So in Levig and Ponseti published in 1980 a 27-year follow-up of all of their patients treated with clubfoot, which, and the results showed 90% satisfaction in appearance with 74% good to excellent functional results. Cooper and Dietz had a 30-year follow-up with 78% excellent or good outcome. People from Iowa did a slight modification to the Ponseti method. They started hyperabduction of the foot, which produced a 98% success rate. And they recommended long-term bracing to up to 4 years, which reduced the relapse rate from 56% to 11%. They also accelerated the Ponseti method. So they found out that there's no difference between outcomes if you shorten the days between casts from 7 to 5 days. But can the Iowa results be replicated? So these are the results from other centers. If you Google Scholar Clubfoot and results, you'll see a lot of studies that show that the results can be replicated. Baltimore and Israel have 89% good outcomes. India has 100% initial correction with a 5% relapse, while studies in Portugal 100% initial correction and 8% relapse rate. Does it matter when Ponseti casting starts? According to Alves, there's no difference if you start before 6 months of age. For Morquende, even neglected clubfoot up to 9 years of age can have a successful outcome. Spiegel and Noguera did serial casting on adolescent and young adults with good results. So how do we know if our casts are working? So we use the Pirani scoring. The Pirani scoring is a scoring system that looks at the lateral border of your foot, the medial crease of your foot, the palpability of your talar head, the posterior crease, the correction of the equinus, and the palpability of the heel. So you have a 6/6 for the worst kind of a club foot, while a 0/6 for the normal foot. So you do this every time you cast or before you cast a patient to see the progression or the regression, or if your serial casting is not working. Okay. So the Pirani scoring has good inter-observer reliability, and there is a positive correlation between the initial Pirani score. What does this mean? So the higher your initial Pirani score, the more likely that you'll need a tenotomy, and the more likely that you will have a higher number of cast changes to correct the deformity. So worldwide literature tells us that there are around in between 3 to 9 cast changes before correction. In a local data in PGH in 2006, our institution had 12 cast changes for correction, which was improved further in 2011. We reduced it to 10 cast changes. And quite recently, we brought it down some more to 9 cast changes. Unfortunately, relapses cannot be eliminated in the treatment of clubfoot. In Ponseti's study, in his third-year follow-up, we find that only 38% did not have any relapse. So 62% had a relapse of their clubfoot deformity. Okay. So they found out that the relapse was related to the compliance of the foot abduction braces. In this series of pictures here are different types of foot abduction braces. So this is your Steenbeek brace. This is your IO brace, and this is your Mitchell boots and bar. So for those who are non-compliant, you'll have 183 times more likely of a relapse if you don't wear your boots. And in a study by Marquende, 17 times greater odds of relapsing. So I cannot um, overemphasize the need to persist with the foot abduction braces. So in case you find a relapse, here's a recommendation from the IO group. So you first repeat your serial casting or repeat your tenotomy, maybe add a tibialis anterior tendon transfer, and if it really does not want to correct, you do your limited posterior release. So how does the Ponseti method compare to the other methods? So before Ponseti came along, we used the kite method. The fulcrum of the kite method is the calcaneocuboid joint as compared to the Ponseti method, wherein the fulcrum is your talonavicular joint. Kite enjoyed a 90% correction rate. However, it took months to correct, and these results were never reproduced in literature. Head-to-head studies between the Ponseti and kite had similar success rates. However, Ponseti had fewer cast changes and faster reduction. There's also the French method of daily physiotherapy and then casting. They have similar outcomes with the Ponseti method. However, this is less likely to be chosen by parents because of the amount of time they spend in the hospital. They need to bring their babies into the hospital every day to undergo daily PT and casting. So how about the non-idiopathic clubfoot, which are challenging because of the foot's stiffness, resistance to correction, and tendency to relapse? There are studies that first-line treatment are successful in arthrogryposis and spina bifida. So just because you have non-idiopathic clubfoot does not mean you do not start Ponseti method. You still do the Ponseti casting even if you have a non-idiopathic clubfoot. So we have local data regarding this. Although there's a significant difference in mean cast changes between idiopathic clubfoot and those with arthrogryposis, because um, with arthrogryposis and arthrogryposis has 23 times more are more likely to be operated on. These operations are limited to a simple posterior release. Gone are the days when we do our posteromedial releases. So in summary, so these are the questions that hopefully have been answered by my talk this morning. So does it matter when serial casting is initiated? No, as long as there are other methods in the treatment of clubfoot. You have your kite and your French method of physiotherapy. Non-idiopathic clubfoot, so what about it? It still responds to serial casting and it lessens the degree of the operation. So I'd like to plug our PGH Clubfoot Clinic, which we run every Tuesday and Wednesdays. You can come to the PGH Outpatient Department, 7 a.m., room 105. We are partnered with Miracle Feet and the Philippine Band of Mercy, wherein they give free plaster of Paris as well as free braces, free abduction orthosis to all patients enrolled in our treatment. So with that, thank you very much.
Okay, thank you very much, Dr. Sumpaico, for a very, very good lecture. So maybe I know some of these questions you've already answered, just to give a little more emphasis on the issues that you brought up. When is the earliest time when serial casting can start? If a newborn comes to you within a week of birth, is that a good time to start serial casting?
So the current tenet is cast them as early as possible. Okay? But there are studies that show that there's no difference before 6 months. But in my practice, or majority of the literature says that if you diagnose them early, start them as soon as you diagnose them. So for newborns, it's probably okay to start them 1 week after birth.
So how about the upper age limit? For example, a patient who comes to you who's already walking, maybe 2, 3 years old, with clubfoot, is it still prudent try the Ponseti method?
Yes. That's a very good question, Dr. De La Rosa. Yes, Ponseti is always the first line treatment for anybody with clubfoot, regardless of age. Okay? Studies have shown that the degree of operations, if Ponseti casting fails, the degree of operations is lessened. So before, we usually do a very extensive operation called the posterior medial release, wherein release all the structures behind the ankle and medial to the foot. With serial casting using the Ponseti method, regardless of age, we found out that at least in our local study here in PGH, that 50% of the time we end up with just a simple posterior release. When I say simple posterior release, it's just releasing your Achilles tendon and maybe releasing your posterior tibio-talar joint and subtalar joint.
So, regarding the recurrences, I realize that the recurrences will probably be concentrated on a lot of those syndromic and severe club feet. Do you think how can you say that the treatment for recurrence using a repeat serial casting? No, when do you give up and say that it's probably surgical? How many weeks, or what are the signs for you to say that it's probably a surgical patient?
So the surgical clubfoot is the one which is resistant to the serial casting, or whatever we do, the deformities recur. So as I said earlier, do serial casting on all patients, either new patients or those with recurrences. It's only when your Pirani score plateaus, or if you see that despite serial casting, your foot does not improve, and that's the only time that you offer surgical treatment for your patient. So emphasize Ponseti method first. If there's a plateau in the improvement, then you can offer surgery. So with the syndromic and the neurologic clubfoot, these are the patients which are usually operated on. And unfortunately, even if they are operated on, the results are not as good as those if they were the idiopathic type of clubfoot. So it's very important to temper the expectations of the parents whenever you see a syndromic and neurologic clubfoot. Their expectations might be different from yours, so it's very important to talk to them and level their expectations that it will be a long drawn out battle that we may not win. So when I say we may not win, the patient or their child may end up with repeated surgeries, or we can't, and because of the repeated surgeries, there's no option except for a fusion of the foot. In terms of clubfoot treatment, fusion of the foot is always a last resort, and we only do it in patients wherein we've tried everything. So be sure to tell your patients and level the expectations that these things might happen in the future.
So, Dr. Sumpaico, most of your talk is actually centered on club feet in children. But of course, we being in the Philippines, like most third world countries, a lot of these club feet go untreated until adult life. What if you have an adult patient who comes into you with club feet, or maybe an adolescent who suddenly, is conscious about his appearance, wants his feet suddenly to be corrected after maybe when he's 12, 13 years old, or even older? What are the options available to someone like that?
So for a patient who is an adolescent or an adult, or the older children, options, well, we start off with serial casting. In Morquende's study in 2009, they had fairly good results in the 24 patients, 24 adolescents and young adults that they treated with the serial casting. Spiegel has described this in his study as well. But if that doesn't work, then and if he really wants a flat foot, so you need to tell them that we can get your foot flat, but there's always a possibility that it will be a stiff, or it will be a stiff foot and maybe a painful foot. That has to be clear to the patient. And treatment options left to that for patients who are very old, would be a fusion of the all the joints of the foot, or a patellar fusion, or a triple arthrodesis of the foot. So the operations that I mentioned are all salvage procedures, which make the foot flat, enabling them to actually maybe walk better, or put them make them able to wear a shoe. But in the process of using the joints of the foot, you lose motion in your subtalar joint, or motion in your ankle joint.
So thank you very much. I seem to have no more questions. And on behalf of the OrthoRoCKs webinar series organizing committee, we would like to thank Dr. Carlo Emmanuel Sumpaico for a very, very good talk on Clubfoot. So stay tuned. In a few minutes, we will start with our lecture on the limbing child with Dr. Cielo Balse. So we have a 9-minute break. See you back here in 9 minutes. Thank you.
Thank you very much.